Can we have all the panelists with the cameras on, please? Be all together here. Great. Pedro and Giuseppe, if you can come with us. We have some questions from the audience. There is a question from Giuseppe, for Giuseppe, who says that if you have to combine surgery for autologous breast reconstruction with VLVT and adipose tissue transfer for treating post-mastectomy breast cancer-related lymphedema, what you would suggest?
Yes, it's of course a good question, and it can be a good option. And as also the other speakers say, it's very important to clear very nicely the axilla from the scar. And if we consider the lymphatic transfer only, actually we can evaluate the tissue that we are transferring eventually with the DIP, because by marking the lymphatic channel on the DIP, if we take a very long DIP, 4-zone DIP, eventually the tail of the flap can go already into the axilla. This can be a kind of lymphatic flap as well, if the lymphaxiality is good. Or eventually we can include the epigastric vessel. Most important is to study preoperatively the lymphaxiality and to plan the flap according to the breast reconstruction volume that we want to give to the patient, or the needs of the patient, and then also according to the needing of the axilla.
Okay, thank you. Pedro, you haven't seen differences between the flaps. I mean, different locations of the flaps. They have about similar results as you show in your paper, but so you direct actually from your choice or the availability of the patients. But when are you going to choose a skin paddle to your flap and when not?
Of course, okay. So in cases, because actually the insert of the flap also depends on surgeon's experience and also preference. When I choose a skin paddle is because I will transfer distally, and the skin of the lymphedematosus tissue will not allow me to close directly. So if I know that I will need a skin, of course, I will harvest with a skin pad like a supraclavicular or the groin lymph node flap. But in some cases, the lymphedema we do have excess of skin. So you can just create a pocket and insert the flap behind the skin flaps.
Do you ever feel that you have a restriction of using skin on your flap?
No, actually no.
Okay. Okay, Gemma, what about you? I mean, do you always use skin paddle on your flap?
Yeah, we almost in all cases we use a skin paddle because it's useful just to assess the viability of the flap, and also because it permits just to settle down better the flap. But it's true that sometimes patients feel the flap too bulky after some times. And then we try just to reduce or accommodate, and sometimes we deepitalize the flap.
Okay. Debbie, there is a question that probably is good to answer. What is the ideal timing of the surgery? I mean, Gemma said before that as early we could do it is better probably, but what is your opinion for that?
I agree. The sooner the better, because more than we wait, more the condition aggravates, and there is fibrosis which comes, and everything will be more complicated. So if we can operate, of course, prevention is the best, but if we can operate in early stages, it's better, and we expect to have better results. stage 3 lymphedemas are more difficult to handle, to address and to manage. So the sooner the better.
Yeah, probably everybody agrees to that. And this is a little bit the opposite of what International Society of Lymphology suggested, that is probably we have to wait, do some conservative, and after we have an established lymphedema, to go do the surgery. So probably we all the surgeons, we have to push a little bit the criteria to be on the more preventive stage. Dr. Nguyen, we have a question that we have patients that they have been operated with lymph node transfer or LVA, and they have an improvement of, let's say, 30% of the volume reduction, but they have expectations for more. Would you implant BioBridge with a new lymph node flap, or are you going to use the old one, or the LVAs that already have done?
Yes, and so in my practice, it depends on their clinical presentation when they come in. So if they have a lymph node flap that was previously transfer and/or LVA, we first kind of investigate to see if the flap is viable and functional, and the same with the LVA. And if they are, then what is the residual area of edema? So if the lymph node is transferred in the posterior calf, for example, it tends to kind of help the lower extremity and also the thigh by drainage through gravity towards the lymph node flap. And if they still have, for example, residual edema in the ankle near the foot area, then we may consider doing an additional lymph node transfer in that location. And when we do that, we find that when we use the BioBridge, it acts as a conduit to connect and allows the network between different lymph node basin, bridging different lymphosomes, so that new lymphatic channels has the ability to interconnect and drain in a unidirectional pathway that mirrors the physiologic flow. And so some of our presenters have presented and find that there is benefit in doing multiple lymph node transfer in several locations. And we sort of see the same application as well. But what we found is that, by using the scaffold in this situation to bridge areas of viable lymph node basins or lymph node flaps, it enhances the flow, and we see formation of connecting lymphatic channels between the two sites. So I think it has a role in that way, and we would use it, at the time of the second lymph node transfer. And then sometimes, if it looks like if it's not significant, there's just subtle swelling in the residual areas, not enough to do a lymph node transfer, then I would place the BioBridge. And before we do that, again, we investigate using the lymphatic mapping to see if where there are distal lymphatics that may be sort of isolated and not connected with anything else in areas of dermal backflow, and then using BioBridge to bridge those areas to an area of intact functional lymphatic flow, such as to the groin or to an existing lymph vessel. And again, as seen in the little, the short clip that I showed, that, we found that there are new lymphatic channels that seems to be forming in continuity with the native vessels.
Thank you so much. I think the time has run out. There are some questions for Giuseppe and Pedro at the Q&As. So please, Pedro and Giuseppe, go and answer in personal to these guys on writing. Unfortunately, we have to move to the next session. A big thanks to everyone. Thank you to everybody that you are here together. And really, I would like to see you drinking a glass of wine next to our thalassa, as Depi said before. Looking forward to see you in Greece. Thank you having you here.
Thank you.
Thank you.
Bye.
Bye.